Hello, everybody. A massive welcome to IPC Partners Journal Club in partnership with Arka. My name is Jude and I'm absolutely delighted to be able to chair today's session. And we are celebrating World Hand Hygiene Day. And the World Health Organization strapline is around, it might be gloves, but it's always hand hygiene. And we've got a brilliant topical paper that's been picked by John, Phil and Arka, which we're going to critique today, which is all about the consensus-based guidelines for best practice in selection and use of examination gloves in healthcare settings. I absolutely love this paper, so I cannot wait to hear about this critique. But before we pass on to John and Phil, we are just going to go through a little bit of what the IPC Partners Journal Club is all about, for those of you that haven't been here before. So as we've said already, we're going to pick a really topical paper, and today we've picked one just to, really exciting paper to discuss with you. And we're hoping for lots of discussion, so please do use the chat function, and we want you to use a Q&A so I can throw lots of questions to John and Phil following their short talk. This is a great opportunity for continuous professional development. It's going to exercise your critical thinking skills and hopefully build that confidence for your own independent research. And along the way, have a little bit of fun. Just to let you know that this journal club will be recorded and it will be made available almost instantly after the event, as always. So do look out for that too. Without further ado, I'm going to hand over to Dr. Jon Otter, who's going to talk us through this great paper.
Okay, thanks. Good afternoon, everybody. Hi, Jude. Hi, Phil. Before you go, though, I'm just intrigued to hear what's been going on for you with respect to World Hand Hygiene Day. I mean, is it a bit fraudulent to talk about it because it's not actually World Hand Hygiene Day? We've missed the boat. Was it Monday, Bank Holiday Monday in the UK?
The bank holiday got in the way, but yeah, from our perspective, lots of education, lots of events, training, ward rounds, etc. And it always surprises me just about how engaged people get around hand hygiene, which is great to see. But yeah, it comes around really quickly once a year, doesn't it? But yeah, lots of education, lots of interaction with our clinical and frontline professionals.
I think something that I would say, and we've just seen something come up in the chat, I was going to say exactly the same thing, is that what I love about this Hand Hygiene Day campaign is that it does often last weeks or, at least a week. So I think we're absolutely fine, John, to be talking about this today because everybody is still on it with their campaigning, which is wonderful to see.
Okay, so maybe is that the first ever Journal Club recommendation that we no longer have World Hand Hygiene Day, but we have World Hand Hygiene Week?
I think so.
Or maybe it's World Hand Hygiene Year. But then if it's World Hand Hygiene 1 year, what do we do next year? Do we stop? Oh, I don't know.
Yeah, I think a week's good, and we're getting lots of consensus off the chat. So yeah.
All right, good. Well, thank you. So in my organisation, we had a stand up in one of the kind of high throughput areas. We had a lot of people going past, lots of photos and a bit of social. And it was good fun. And I echo what Phil said, is that people are generally really happy to talk about hand hygiene. And I think people are especially happy and willing to talk about gloves at the moment. It's a really hot topic. And I was so delighted to see that the World Health Organization had included that strapline. It might be gloves, it's always hand hygiene. In their campaign for this year. I think it's very much on topic and something that's absolutely within my own interest and the aims of the organisation I work for, who's running an active gloves off campaign, as I know many are at the moment. I think when I first heard it might be gloves, it's always hand hygiene, I wasn't immediately taken by it. It sounded a little bit nervous, maybe not as definitive as it needs to be, but actually, the more I think about it as a kind of tagline, it's perfect. It's exactly right, because there is uncertainty to be discussed when it comes to the selection and use of gloves. I suppose there's always on the far side of the issue times when you would always wear gloves. It's not debatable. Everybody needs to wear them, and then it becomes a question of how do you wear them most safely. There's then times where you really never need gloves for purely administrative tasks, whereas some people do wear gloves for those. But there's this grey area in the middle, and we could talk about how big that is and how many tasks that covers, where you might choose to wear gloves, you might not choose to, and there's probably arguments either way. So when I'm out and about talking to people, what I really want to hear is that people have made a risk-based decision, and rather than just worn gloves because they've always worn gloves or because the colleague told them to, actually to be able to say and articulate, I am wearing gloves because I can see this as a risk of, say, body fluid exposure, and that's why I've chosen to wear gloves. And I think from my own point of view, even if I disagree with their choice, as long as they've really thought about it and made a proactive decision about whether or not to wear gloves, I'm happy with that, because I think if every healthcare worker all around the world made a proactive decision, we'd be in a much better place with respect to the use of gloves. So the image there is one that I took on the way into a UK hospital with an examination glove on the steps on the way into the hospital site. I don't know whether or not it was from the hospital, but I suspect that it probably was. Whether it's used or unused, I don't know. But I think it illustrates the ubiquitousness. Is that a word? Ubiquity. Anyway, it illustrates that the sheer volume of gloves that we use, and the clear environmental implications that has. I wanted to start with a brief story today, because I had some visitors from overseas many years ago now who came to one of the hospitals I was working at, and we were visiting the critical care unit, and out of the corner of my eye, I saw a member of the team, the healthcare team, the frontline team, put on a pair of gloves and start playing with some tubing from a ventilator, which then fell on the floor, and they picked up the tubing, put it back, fell on the floor again, picked it up again with the gloves, and put it back on the rack. And then they went straight to the patient bed and started to deliver care. And then they started to access the IV device, and I went over and spoke to them. And they didn't even realize they were wearing the gloves. They'd forgotten and not taken them off to undertake hand hygiene. But I think that one incident, whether we like it or not, that does happen from time to time, probably more often than we'd like to think. So to get that change in mindset towards best practice and use of gloves is going to be a life's work for us, really. This is a conversation that we need to keep on having. Okay, let's get down to the paper for today. This article is trying to get us somewhere towards best practice, and I really like the title and the ambition, because we have a long way to go towards best practice. So every guidance document that we can have helps. The group behind this document were not based in the UK, not based in the US, so I think it brings a slightly different perspective to one that those of us working in the UK or the US would be used to seeing, and I think that's a valuable thing. Because of the way the review is structured, and we'll look at the methods in a minute, it goes into more detail around some of the more technical aspects of glove choice than other guidance that I've seen, and I found that quite helpful. So the design is quite simple. It's a qualitative Delphi approach to garner expert opinion from a panel of 30 experts. Jude will tell you in particular my love of quantitative data-based research. I love it. And I've always found qualitative research a little harder to access and get my head around, and perhaps even see value in. I think as I'm getting further into my career / getting a bit older, I'm beginning to see more value in the qualitative type approaches, because it allows you to cover ground that you can't cover using quantitative methods. So the key findings. There's quite a bit in this document around glove production and dispensing, which are two areas of practice, or behind our practice, that aren't perhaps focused on in some of the other guidance documents. There's quite a lot of talk about EN 455, which is a key European testing standard, which covers 4 areas. One is freedom from holes, which is measured by AQL testing. Physical properties, so that's the amount of, in the movies when the doctor puts on the glove, you kind of pull it like that. That's how hard you have to pull it until it breaks. Reactivity to the wearer and shelf life determination makes up EN 455. The guidance recommends pragmatically, I suppose, that the glove should have an AQL of less than 1.5, a tensile strength of more than 6 units. And we'll come on to look at what that means in detail in a sec. The recommendation is to be dispensed one by one and from the cuff, and that the packaging is either recyclable or from recyclable materials, sealable or watertight, and can be disinfected. Now we'll come back to these recommendations around the packaging in a moment, because that is a tricky thing to deliver. So just looking at those sort of physical properties of the glove. So an AQL is a measure of how many defective gloves are detected during manufacture. Health gloves typically have an AQL of 1.5 with a higher defect rate, or of 0.65, which has a lower defect rate. So the lower the AQL, the lower the defect rate. So just to put some numbers to that, a glove with an AQL of 0.65 has a 57% lower defect rate than a glove with an AQL of 1.5. Tensile strength is the measure of, the pull test, and gloves are typically 9 newtons or 6 newtons, depending on how strong they are. Packaging and inspection during production are important factors in the assurance of the product, and supply chain is an increasingly important consideration. Many of our gloves come from a long way away from Asia, but that introduces two things. One is a lack of assurance around supply, but also a lack of sustainability in the supply chain. And increasingly, we're beginning to try and make our healthcare delivery as green and sustainable as is possible. So this is a table from the paper, which talks about the fundamental parameters that this expert group were looking for in the glove. We talked about that AQL value and the newtons, and from the cuff and the packaging characteristics and the one by one removal of the gloves. I think this is, as a wish list, quite difficult to actually achieve, but I love the aspiration here. So moving on then through the key findings of the expert group, and away from the sort of technical characteristics of the gloves, training was a really important part of the outcome that the expert group were looking for. Staff needed to have knowledge around which gloves to use, when to use gloves and when not, but also that they felt that more education was required around knowledge of the unintended consequences of glove overuse, which I'd agree with. They suggested training not only of healthcare staff themselves, but also of patients, caregivers, family members as well, and that this was an important but actually not often discussed issue. There was quite a bit of focus on wound care, where you need sterile and non-sterile gloves, which was helpful to see, and a strong theme of sustainability around location of manufacture and also method of manufacture and transport. So these are the parameters of the glove around quality, and again, just to reiterate here that this focus on sustainability around recyclable packaging materials, European production. An interesting recommendation around packaging remaining watertight until opened in a clinical setting. A recommendation around glove inspection and particulate-free packaging, and the environment in which the gloves were produced. I enjoyed reading this because these are not the sort of issues that I'm used to understanding or talking about when it comes to gloves. So I've tried here, this is not from the paper, this is my own thoughts, just to try and pull it together around the consequences of incorrect glove use. So I think there's two major consequences if we make poor decisions around glove use. So one is infection risk. If we use non-sterile gloves when we should be using sterile, if the glove tears during use, or if it's dispensed incorrectly such that we end up contaminating the glove as it's put on our hands, then we introduce infection risk. Conversely, gloves are overused, and that's resource we could better spend elsewhere if we choose sterile rather than non-sterile gloves, because they're more expensive to buy and they have more environmental impact. Or even if we use an over-specified non-sterile glove when we could get away with a lower quality one. And over-dispensing, if, for example, and you'll have been there if you worked in healthcare, you go to the glove box, you pull out one glove and you get 10. What do you do with the other 9? You should throw them away, but often they're stuffed back into the glove box and they go in your pocket for use later. I think that's a reality that we see. So strengths and limitations. I found the overall document substantial in length, long enough, but actually the number of recommendations at the end were fairly small and were limited to a fairly small scope of the areas that the document covered. I would have liked to have seen some more definitive recommendations on some of the more controversial aspects of glove use. So they talked quite a bit about glove use during wound care, but they didn't talk about vascular access or even particularly when to choose sterile and non-sterile gloves in most circumstances. In terms of waste, the document does refer to waste and the importance of making sure that we're using the appropriate waste stream locally. And I understand why they couldn't have been more specific about which waste stream to use, because it varies so much from country to country. But I think it would have been good to try and open up a discussion a bit more explicitly around alternative and less impactful waste streams. So in this country, we talk about offensive waste, which is somewhere between clinical and domestic waste, which may be appropriate for gloves in some circumstances. So points for discussion. Now, this could be a very big slide because there's a lot we could talk about when it comes to glove and glove choice. But I like the qualitative approach. Having said I like quantitative research more, I have to acknowledge on this occasion that this qualitative approach was helpful because it allowed us to talk about some areas of glove selection that a literature-based review could only ever say there's no evidence for this. So gathering expert opinion on practical points we have to address in our day-to-day practice was helpful to me. Are we paying enough attention to the physical characteristics of the gloves used in whatever organization we're working in? We all know that cheapo supplies are not always best. If we get gloves that tear too easily, or gowns or aprons or whatever else it is, then yes, they might be cheaper per item, but it's a false economy. Are there common tasks when it's safe for us to choose not to wear gloves at all? And I'd like to talk particularly, not necessarily today, but in general, that there's more discussions to be had about vascular access and some elements of transmission-based precautions as well. Are there some areas of our practice where sterile gloves are overused and could be replaced with cheaper and more sustainable non-sterile gloves? And I'm thinking particularly about dentistry, maybe wound care, some aspects of critical care, maybe even sometimes in theatres. And the other area is non-invasive or minimally invasive procedures as well. So to bring my introduction to a conclusion and to take us to the Q&A, what this means for IPC? Well, we need to continue this conversation about gloves at every opportunity. Our aim must be to ensure that glove use is minimized and that when we choose to use gloves, that the physical properties of the gloves that we use are suitable for the task at hand. And finally, that we consider the sustainability impact of all that we do in IPC. That's such an important driver for us and for future generations. So with that, Jude, Phil, I'm going to hand back to you and let's see what's happening in the Q&A.
Thanks, John. Really enjoyed your critique of that. As John said, please put your questions in the Q&A or the chat and we will pose those to John. John, as John alluded, is more quantitative. Well, I'm polar opposite. I'm a qualitative girl. So I absolutely love this paper, and I'm really leaning towards these consensus-based studies. I actually really like them, and I really like this methodology. I've been lucky enough to be involved in something similar on a different IPC topic, and they are really robust. Like, I was really surprised as being a participant in one of these, just how robust the methodology is. So I guess my first question, I'm just going to ask you, perhaps yourself, John and Phil, on what you thought of the methodology having read the paper, and did you feel as strongly about that robustness as I did?
I can take that, Phil, to kick us off. I agree with you, Jude. I think so far as qualitative methodology goes, it was robust, it was strong. They had several different workshops to try and distill it down to the last dregs of information and come to a consensus. I wonder whether that same methodology was the reason why they actually ended up with relatively few consensus recommendations. because they went through a rigorous process to get to consensus. I suspect many of the other areas that I would have loved the document to comment on, I'm sure they talked about it in the narrative, but perhaps didn't reach sufficient consensus to actually make a recommendation.
Yeah, I agree. Actually, I was very surprised that there was only signed kind of 5 recommendations there. I would have expected sort of more coming through that. So yeah, I'm with you on that. A couple of bits that just before sort of some of the questions start coming through. I guess one of the things that came out of the paper to me was around kind of the conversation around PPE being a medical device. And I wonder whether people realise that, and I wonder whether having that sort of a language to PPE would help people in how they use it and that appropriate use of gloves and other PPE. I don't know what you think about that.
Yeah, I agree. I think probably because it's used so commonly. I mean, especially during the pandemic, but even post-pandemic, PPE is something that most healthcare workers would use pretty much every day in whatever aspect of healthcare they're in. Perhaps it's easy to forget that it is a device of some classification, and it does have pretty rigorous standards behind it, and clear instructions for use around how to use it and how not. So perhaps our volume of use and familiarity with PPE means that we perhaps underestimate the impact of what we could be doing with it.
Yeah, absolutely.
I think, sorry, Jude, I think, just carrying on from that, I think you talked about it in your slides, John, but this element and idea of training and how important it is to ensure that appropriate use. And maybe I completely agree, that PPE around gloves have been commoditized, maybe, we just take them for granted. We know they're always going to be there. They're always in abundant supply. So do people just, grab them by kind of repeat habit, and they're not actually thinking about the task that's involved? And I think, training to kind of give people the courage to make the right decision around glove choice. And then, going back to what Jude was saying about ensuring that you might have, different PP available for the different tasks, etc., fits really nicely. I think the training element is something that I'm really interested in. And where do you think, John, in the organisation that responsibility should fit or lie? Is it with the IPC team? Is it maybe a more granular level, at the ward level? What do you think about training and the provision of it?
So specifically for the use of gloves, where should the training sit within an organisation? Is that the question?
Correct.
Yeah, can I give that one back to you or Jude? I think it's too hard. So I think that there's definitely a big chunk of training responsibility that sits firmly with IPC there. According to the Health and Social Care Act, we have a responsibility to make sure that our workforce has the appropriate skills and training in order to keep themselves and also our patients safe during the delivery of healthcare. So I think whatever core routine training program we have, it's a responsibility to make sure that it includes the appropriate use of gloves. However, that being said, that's not going to be sufficient to promote and get us towards best practice in glove use. That absolutely needs organizational leaders outside of IPC and ward level leadership or clinical area level leadership to make sure that the culture locally is appropriate. I've seen a lot of really good work done in EDs, for example, around gloves with some champions who get excited, in critical care as well, to support a move away from gloves on to gloves off, for example.
And we've got a bit of activity in the chat around this, so I'm just going to come in a little bit just around the overuse of gloves, I suppose. Diane, thank you for your comment. She's put this is a really hot topic in her team. Currently involved with theatre to attempt to solve this overuse of gloves, and much of this is unlearning bad practices, and much of glove use seems to be habitual and not risk assessed. And this links in with that training question, doesn't it? Actually, are we hitting that training right? Are we pushing that risk assessment? Because that's what we want people to do, right? We want them to risk assess and make the decision based on that risk assessment, not just I always wear gloves for this, because it's got to be that ongoing risk assessment. So thank you, Diane, for that. That's really helpful. And then I'm just going to switch to the chat a second, because Sharon says that she did an audit in her organisation on glove use, and staff actually told them that they were confused on when to wear gloves, and particularly following on from the pandemic. So again, I think from some of these conversations, I don't know about you, I think maybe we need to relook at what we're actually putting into our training around glove use, and whether we're using that risk assessment enough. I don't know what you think, John.
Yeah, I mean, just referring back to the pandemic, I remember the dark days when the national guidance came around in the UK that said pretty much universal gloves. Every single patient contact involved a piece of plastic on the hands between you and the patient. In hindsight, I mean, I felt at the time that was the wrong approach, but there was so much going on, it just wasn't the time to have a big battle. And where I was working, we implemented that approach. But I think we're still 5 years later, living with the legacy of those COVID regulations around the overuse of gloves. And I think getting staff to move away from them is a bit of a hearts and mind piece. I had a conversation with a medical ward round. I can't even remember the clinical area it was, but it was just after we'd launched our Gloves Off campaign. And I said to them, we've just launched a Gloves Off campaign. You don't need to wear gloves during this ward round. You're not doing any direct patient contact, let alone contact with body fluids. And one of the consultants said, well, you told me to, John. That's why we're wearing gloves, because you've been saying you need to for the last 3 or 4 years. So I think it's sort of come home to roost slightly that it's the original COVID IPC guidance that's kind of put us in this place with almost universal use of gloves, or trying to move away from that. To your point on training, I think where do we get this into our training? There's so many things we need to tell our staff, aren't there, around IPC? It's a huge knowledge and information sharing exercise. I don't think we can do it all in one. We can't get new starters to think about gloves and vascular lines and cleaning equipment, decolonization, screening, all the things we want them to do. It's just too much. So I think we probably need to be quite selective at the time of induction, and save the more detailed focus on certain areas for a campaign-based approach. But I mean, that's off the top of my head. Happy to hear your thoughts on that.
Yeah, I think you're right. I think giving everyone everything all at once, people can't consolidate it, can they, effectively? We've got a couple of questions, John, through the Q&A. Phil, I don't know whether you want to keep it on top of the chat. It's going a bit frantic on both ends, so just so we don't miss anything. We've got a great question. Yeah, brilliant. So what are your thoughts on the location of gloves? Are the dispensers located in strategic places? Good question.
Well, if the gloves are located at or outside the entrance to the ward, as sometimes happens, then absolutely not, because we're then effectively forcing staff to walk across the ward with gloves, that we then approach them and say, you're walking across the wards with gloves, why are you doing that? And they'll say, because you put the dispensers by the door. And I think there's sort of a microcosm of the same issue when you have a multi-occupancy bay or even a single room. The best practice is to have the gloves at the point of care. Exactly how we do that is tricky to conceive. I mean, I don't think we necessarily want cardboard boxes immediately by the point of care, but there may be some other glove dispensing options that might be more appropriate to be genuinely by the point of care. But I think, from my point of view, as close to the patient bedside as is possible, because then you can don the gloves immediately before the task, doff them, dispose of them, and re-glove for the next task.
Yeah. Absolutely, and I guess that will look different in different settings, wasn't it? That's a bit easier on a ward, but maybe community settings and stuff, we need to think a little bit more sort of agilely, I guess, about how we do that. And we've had another question really around, should gloves be at the bedside? I think you've answered that one, John. But really interesting question alongside with that, thank you, is actually, should we be reducing the number of gloves in a box to stop this? There's a lot in this paper around the risks of contamination of unused gloves, which I thought was really quite critical. And yeah, that's a great question. Do we have any data on how many are discarded or not used after the patient's been discharged?
What do you think, Phil? Smaller volumes, would that help?
Yeah, potentially. I mean, I've written down in my notes this idea around false economy, and thinking about gloves and how they're made up, and I think there's this role or this terminology around commoditization of gloves. But yeah, I think that's a really interesting concept. I mean, I think it's a human behavior thing as well. Maybe if we reduce the number of gloves in a box, we might use them more sparingly. Like you said in your talk, John, how many times have you gone in to pick out a glove and you've picked out 9 or 10 pairs and you just shove them back in, and then you've kind of defeated the whole concept of keeping them as single use, or that idea of contaminating them. So yeah, I actually really like that idea of smaller numbers in boxes.
And following on from that, and going back to the point of care issue, it's sort of related. We have little personal dispensers of hand hygiene products, don't we? Do we need to have like a separate little glove holster that we can clip to a belt? And
Just
maybe that
created
brings
an innovation, John.
A bit like your
Right to the
doggy
point.
bags, John.
Yeah, exactly.
Your dog walk sort of thing.
Get your lunch and your dog poo all together in one little bag to take with you to the ward. I'm not suggesting that, by the way. But yeah, personal dispensers. There you go. There's an idea for innovation.
Maybe I'll just cover a couple of the comments in the chat as a bit of a segue. So, lots of comments on inappropriate use. Martha writes, staff seem very fond of wearing gloves just in case. It's incredibly difficult to change habits once they're established. It feels they're often worn without thinking about the task or situation. Completely agree. And I think, that highlights the need for education as well. This is a really interesting one.
Phil, sorry, can I just comment on that one before you go to the other one? So that's a really important point, and something we've talked about really recently, due to a change in other not gloves but another type of PPE. The interaction with a patient is inherently unpredictable, and there are inherent risks that are always going to be there. I think you could probably argue that due to that unpredictability, we should always wear all types of PPE, everything, including overcoats and hats and tails. But that obviously doesn't make sense. So I think from my point of view, it's helpful to talk about kind of risk reduction. What's actually likely to happen during this patient interaction based on experience and evidence, and wear PPE accordingly, rather than tipping the balance towards what could happen. Because yeah, like I said, it's inherently unpredictable.
Yeah, agree. Really good point. I was going to go on and talk about Sam's comment saying that people often scurry off to put gloves on when they see me as an IPC nurse doing my rounds, and some of the conversations you can have around that are interesting. Lots of people as well talking about how you can kind of support better use of gloves or reduction in gloves. So a lot of people sharing around sustainability. So Christine is talking about the use of sustainability and how much waste is generated with gloves. Sharon has shared some of her experience about huge reductions in carbon footprint in terms of education sessions and posters when completing hand hygiene audits, and making it part of their day-to-day conversations. I think that's a really good point, is how we've talked about education and the requirement for it. So how do we build this into our kind of day-to-day conversations with our staff? Jude, there's still loads of questions or comments in the chat, so I'll go back to you.
Yeah, sure. Yeah. So we've got another question about community teams have more limited access to gloves. Should we look into their practice? Can it be transferred to acute settings? What do you think of that?
So I suppose that behind that comment is that community teams have kind of nailed it, that they go armed with the amount of PPE that they need for the patient interaction. They can't carry around with them every item of PPE under the sun. They have to properly anticipate what they're going to be doing with the patient and what they're probably going to need. So I do think there's some learning from that resource poor environment, if you know what I mean, that could be translated into an acute setting where perhaps it's too easy to have availability of loads of PPE close to the point of care. Whereas what we need to be doing is almost producing an individualized procedure pack for whatever we're going to do, and say, I'm probably going to need a couple of pairs of gloves. I'll need an apron. May or may not need a mask. So that's quite an interesting thought.
Yeah, and I think the thing to recognise here that there are times when you do need gloves and you do need other PPE, and like you say, it's that risk assessment and that assessing what procedure am I carrying out and what might that risk be. So therefore, what PPE do I need to use? And I just think just bringing in just something from the study itself. One of the discussions from the consensus was around, gloves don't offer complete protection. and that links us back into the need for hand hygiene before we don and doff gloves, which takes us to the strapline for World Health Hygiene Day. But I just think, you know, again, we're going around in a bit of a circle in terms of that then links back to training, because actually people don't have this self-preservation. I'm completely protected because I've got these gloves on, and actually they're not going to offer me the complete package. However, they're going to minimize risk, and then I need to clean my hands afterwards. And I just wonder, it's that language, isn't it, and just making people understand actually what protection that those gloves are giving, and then we still need to do the hand hygiene afterwards, after removing them, and that's a massive gap, isn't it? We always miss that. We always see that those steps are missed.
Yeah, I agree. I think it's just trying to find a balance, and it's trying to, you know, there's just a comment here from Elizabeth talking about empowering staff to critically think about the requirement of gloves for the task they're undertaking. I think that summed it up really well. But I think often, you know, going back to some of the other comments in the chat around, you know, IPC and thinking, oh, where are my gloves? You know, I've got to go and grab them because IPC are on the ward. That actually it should be part of a conversation, that we want to encourage people to ask questions around the right and correct use of gloves, and then utilize IPC experience, talking about in what situations, what scenarios they should be used. So I think it's, you know, it's trying to get a balance. And I think if we're doing education around appropriate use of gloves, why not bring in hand hygiene as well and talk about the importance of that in part of our care of our patients, and trying to get people to think, you know, more critically around the task that they're undertaking, but how, you know, hand hygiene plays into and supports effectively the correct usage of gloves in our organisations.
Yeah. Absolutely. And we've got a great question here. Gloves and its use in labs. Should we extend the campaign to the labs too? What are your thoughts?
Yeah, well, I'm from a lab background, so this is taking me home. Yeah, I suppose if you're doing your job right, let's say streaking a plate in a microbiology lab, you shouldn't be getting the organism on your hands. We're not creating little plumes of organisms. So I think there are a lot of lab tasks where we could move away from the routine use of gloves. I think it's a really good point. I think there's probably other areas of the hospital where we could use the same logic. I'm thinking maybe about catering, where I'd imagine quite a lot of gloves are used in the kitchen as well. There's probably other areas too.
Yeah, great. We've had a really great question in the chat from Kareen. Thank you. The WHO and IPC manual recommend gloves dispensing from the cuff. Where do you see added value in this concept, taking into account the current state of hand hygiene?
Yeah, so there's some great studies showing that if you do hand sampling for somebody either coming to a patient room or coming to put on a pair of gloves, you do often find contamination of the hands with significant organisms when they arrive at you know, with you, having, you know, in theory done hand hygiene by that point. So we know that doesn't always happen. If you go into the glove box, have a good rummage around, you could end up contaminating not only the surfaces of the gloves that you're going to be caring for the patient with, but also the dispensing material itself and the next glove that's coming out. So I think the WHO and National IPC manual recommendation to dispense from the cuff is a very good one. It's one that was reflected in this latest consensus document. However, it's quite difficult to implement because of the way that most glove dispensing systems are configured at the moment.
Yeah, really helpful, really helpful. We've got loads of questions coming through, so we're going to bit and bob a bit all over the place, if that's all right. Lizzie Perry has just put, what does the panel think about the blanket recommendation of gloves for droplet precautions within the national manual? So the national manual is something that is used within England, so that might not be relevant for everybody on the call, but yeah, question for you.
Yeah, so just for context, in the national manual, we've got transmission-based precautions as a family of precautions, which includes contact, droplet, and airborne precautions. Contact precautions, the latest version, and this is a change from the historic position, doesn't recommend gloves for all patient contact. For a contact organism, it's only if you're going to have body fluid exposure. Whereas for droplet and airborne precautions, the national manual does recommend routine use of gloves for all patient contact. So I think probably by the same logic as for contact precautions, I think you could make a pretty solid case to say that for droplet and even for airborne, you could take a view of the patient in front of you and the task at hand and say, what am I going to do with this patient? And what are the risks of contaminating my hand? And I suppose worst case scenario is that you actually do contaminate your hand with a significant organism, at which point you should always be washing your hands or decontaminating them with an alcohol-based product, or a suitable alternative after that patient interaction. So it's not a complete disaster if you do contaminate your bare hand. I think probably the thing to avoid is contaminating your bare hand with body fluids, and that's why the recommendation is there for gloves, because we know that even thorough hand washing is not always perfect in reducing that contamination. So I think in future I could see a way away from that recommendation around droplet and even perhaps airborne.
Yeah, I absolutely agree with you, John, there. Absolutely.
There's another really good, sorry, Jude, just to pick up on the chat. I really like this from Faye. It says, if you remind staff that gloves aren't sterile, staff do tend to rethink about what they think gloves are appropriate for. And it's saying that their organisation in Chester, they also measure soap and sanitizer use over a monthly basis to triangulate it with glove use and hand hygiene observation scores, because they're intrinsically linked. Yeah, I mean, if you've got the resource to do it, what a fantastic bit of observational study.
Yeah, absolutely. I'm going to throw a question in there, if that's all right, that we've not touched on too much on here, is around your thoughts on the recyclable and biodegradable gloves. Do you think that people will buy into that?
So I think recyclable as in you use the gloves and they're decontaminated, or that the material is such that it can be recycled after being discarded.
Yeah, I think can be recycled. Yeah.
Okay. Yeah, I think that's possibly useful as a way forward. I think the challenge is going to be if a glove is contaminated during patient care, it becomes clinical waste, and I think it's quite difficult to find a clinical waste decontamination procedure that's going to work for something like a glove. You could do it for a medical device, a bigger medical device like an endoscope or something, but I think it's quite hard to conceive a waste flow that would work with that. But certainly wouldn't rule it out. Something we should be looking at.
Brilliant, great. So we've got just looking at the chat. What can you say with gloves being washed when used, cleaning in a clean bay and reused?
So I think the idea of gloves being washed isn't something that I would support particularly. There is some discussion about whether a glove that's heavily contaminated could be washed before being removed in order to reduce the risk of hand contamination when the glove is removed. But I think that probably introduces other risks. Yeah.
Great, thank you. I guess just another reflection from myself, if that's all right, seeing as we've gone quiet on the chat, was around the study goes into a lot of detail about technique for putting on, and again, it goes back to that only touch cuff. So I think we've discussed this a little bit, but again, probably linking back into training, and actually the right way to put your gloves on does make a difference and will prevent sort of unused gloves getting contaminated, etc. And I just thought it was really nice that this study picked that out as an observation, because again, they're things that we don't usually always concentrate on, do we? It's either have you got gloves on or off, and so I really like the way it picked that out.
Yeah, and the natural extension of that is how do we take the gloves off safely as well?
Absolutely,
because if we're putting them on really carefully and then just ripping them off, actually it's when they're contaminated that's the critical control point.
Yeah, absolutely. That pinch, pull out, invert. Yeah, how many people actually do that?
Yeah, I think I agree. I think it's just trying to find that balance. We've probably identified loads of different themes that we can educate here in terms of appropriate use of gloves. So I think one of the comments in the chat was about day-to-day conversations and how you can then try and change behaviours and habits. We're not going to be able to sit all of our staff down in one room in half an hour and talk about all these changes. But I think if you're doing it gradually and little and often, then it can work. But yeah, I think we've identified education is the key to anything.
Brilliant. Thank you very much. I think that rounds up our discussion really nicely. I'd just like to say a massive thank you to Arka for partnering with IPC Partners today. And I'm now going to hand over to John and Phil, who will tell us what is up next.
Thanks very much, Jude. Great job of sharing as always. And thank you, everybody. Loads of conversation in the chat. We're really sorry if we didn't get to your questions, but we do have 45 minutes, so we're out of time. And thanks, Jon. Really nicely presented. So we've got a nice schedule of journal clubs building. We've got 11th of June. We've got our second partnership of IPC Partners with the Healthcare Infection Society. We'll be covering in that session a MRSA journal collection. So Jon and I will be running through a paper each in that session and a slightly extended session for that one. And then also we're delighted to partner with Mondaki. If you were on just before we started this journal club, we talked about this very briefly. Jon and I will be running through a paper around risk factors for post-operative Staph aureus infection. As a reminder, all our recordings are on our YouTube channel, and if you're ever interested in becoming a guest on the IPC Partners Journal Club, we'd love to hear from you. Our contact details are on this slide, or you can visit our website. Thanks very much, Jude, Jon, and happy World Hand Hygiene Week, not day. And again, thank you to Arka for their partnership.